confirm it's started, Councillor Fairhurst.
Thank you. I'd like to say welcome to this meeting of the Health and Wellbeing Board. This meeting is being held remotely and the members are in attendance via video conferencing. The meeting is being live streamed and will also be available for repeated viewing. During the meeting, if a member wishes to speak, they will indicate as requested and we will call them to speak in turn. Member services will check for raised hands or requests to speak. I'm going to begin by reading out the names of the members on the committee so they can confirm their attendance for the public record. I'm Councillor Liz Fairhurst and I chair this board. Dr. Barbara Rushton.
Hello, yes, I'm Dr. Barbara Rushton. I'm Clinical Chair of South Eastern Hampshire CCG and the Deputy Chair.
Thank you. Councillor Judith Krajewski.
Yes, good morning, Councillor Fairhurst. I'm the Executive Member for Public Health at Hampshire County Council.
Thank you. Councillor Patricia Stallard.
Thank you. Good morning, Councillor Fairhurst. I'm Patricia Stallard. I'm the Executive League Member for Children and Children's Services.
Thank you. Graham Allen.
Yes, thank you. Good morning. Graham Allen, Director of Adults Health and Care at Hampshire County Council.
Simon Bryant.
Good morning, Simon Bryant, Director of Public Health.
Thank you. Steve Crocker.
Morning, it's Steve Crocker, I'm Director of Children's Services.
Thank you. Dr. Peter Bibberway.
Hi, good morning, Councillor Fairhurst. I'm the Executive Lead and Chair of the Frimley Academy, representing North East Hampshire and Farnham CCG.
Thank you. Dr. David Chivers.
Good morning, yes, Clinical Chair, Fareham and Gosport CCG.
Thank you. Dr. Rory Honey.
Good morning, Councillor Fairhurst. Rory Honey, GP, Public Health Doctor and Deputising for Sarah Schofield, West Hampshire CCG.
Dr. Nicola Decker, but I think we've received apologies.
That's right. I think we're going to have Dr. Nisbet with us today. I'm not sure if he's arrived as yet.
Okay. Dr. Nisbet? No. Councillor Anne Crampton, again, I think we've had apologies. Councillor Philip Raffaelli, I think I've seen Councillor Philip.
Good morning, Councillor Fairhurst. Yes, Dr. Philip Raffaelli, Councillor from Gosport Borough Council and one of the district representatives. Thank you.
Welcome. Nick Tunston.
Yeah, it's Nick Tunston, Councillor Fairhurst. Thank you. Chief Executive of Eastleigh Borough Council, but I'm here representing the Hampshire and Isle of Wight Chief Executives groups and deputising for Tricia Hughes.
Super, thank you. Christine Holloway.
Hello, I'm a representative from Health Watch Hampshire.
Welcome, Christine. Michael Lane isn't here. Is his deputy Anja Kimberley here?
Good morning, Anja Kimberley, Head of Performance and Information and representing the Police and Crime Commissioner.
Thank you. Julie Ames.
Morning, Julie Ames, Chief Executive of Energise Me, and I'm here representing the voluntary sector.
Good. Alex Whitfield, I have seen Alex.
Yes, hello, I'm Alex Whitfield. I'm Chief Executive of Hampshire Hospitals and I'm here representing the Acute Hospital NHS Trusts.
Rob Cole.
Yes, good morning everybody. Rob Cole, Assistant Director for Hampshire Fire and Rescue Service.
Good, thank you. Samai, are there any deputies, sorry, everyone, are any of you deputies that I haven't called your name out?
I think Councillor Nisbet's just joined us. Oh, sorry, Dr. Nisbet's just joined us, so I think we're all set.
Good, thank you.
And Councillor Fairhurst, I've just joined Keith Mann's leader of the council.
Thank you, Keith. And also, as we said earlier, in attendance, we've got Councillor Perry and Councillor Brooks, who are both welcome to be here. And if they want to speak, feel free to.
And I'm Dr. Stephen Clark. Just say I'm the clinical lead for North East Hampshire and Farnham. Actually, Peter Bibway is also on the call, so I'm just going to, in the background, liaise with Peter as to who will stay on the call. But I'm from North East Hampshire and Farnham as well, CCG.
Well, welcome anyway. So yes.
Good morning, Councillor Fairhurst. It's Councillor Roger Huxtable speaking. I'm here as an observer of the Health and Wellbeing Board on behalf of the Health and Social Care Select Committee.
Thank you, Roger. Right, is that all? Right.
Hello as well. I'm Dr. Matt Nisbet. I'm clinical lead for North Hampshire CCG.
Welcome. Thank you. All decisions will be reached this morning through a vote conducted by a poll for, against, abstain, and then for. And members will indicate their vote by clicking unmute and sharing the option they support. The vote will be conducted by a Democratic and Member Services officer and the result confirmed before moving on to the next agenda. I would like to remind members that the Constitution standing orders will apply, so please keep your microphone muted unless you've been called to speak. And please remember that you may be visible on the screen to the public and to other members, even when you are not speaking. We've had, Samaya, do you want to read out the apologies or do you feel we've done them?
Yes, I can just quickly go through them. We've received apologies from Mark Cubbin, Michael Lane, Ron Shields and his deputy Sue Harriman, Patricia Hughes, David Radbourne, his deputy Amanda Lyons, Dr. Schofield, Nicola Decker and Anne Crampton.
Thank you. Can I remind all members of the board, if they have an interest in any item to be discussed today, please declare it at the time of the relevant debate. If we go to the minutes of the previous meeting held on the 2nd of July, is everyone happy with the minutes? Again, can we just raise hands if we're happy or just not? Yeah, thank you, Alex. Everyone else happy with the minutes of the last meeting? Julie is, yeah.
Thank you, Councillor Fairhurst. Because of the problem with hands, if everyone can just sort of unmute and do a group yes, that will be very helpful. Thank you.
Would it be easier to have, if they unmute and say no if they're not happy?
Yes, yes, exactly. So that's how we'll be doing the voting, is we'll do the abstain and then against, and then everybody can do a group aye.
All right. Does anyone not agree with the minutes?
It's not a disagreement, but I do have a question to raise about one of the things in it after they've been approved, please.
Okay, so shall we approve them and then come back to you, Christine? So let's say we've approved them. Christine, you have a problem with an item?
It's not a problem, it's just a question. Minute 121 talks about where we're going with co-production, and one of the things in it says the strategic leadership sponsor could take on the oversight. I was just wondering if you're yet able to tell us who the new strategic leadership sponsor is, because this has been on hold waiting for that appointment.
Could I jump in, Councillor Fairhurst? Yes. I think Christina had confirmed to you via email that it's going to be Simon Bryant, and you had sent him an email to follow up. And he will get back to you in due course, if that's all right.
That's absolutely fine. I wasn't quite sure whether he'd officially started yet.
Yes, thank you.
Okay, we have no deputations, so I'll move on to announcements. And members, you may be aware of the Public Health, Adult Social Care in Hampshire and Isle of Wight COVID-19 updates have recently been shared at the HASC. We are continuing to follow along closely, and the weekly COVID-19 Hampshire update is a useful source for the most up-to-date information. I think you've all been circulated a Healthy Homes survey as part of the Healthier Communities theme, which we support as a board. Please could you share extensively with all your colleagues and organisations. We've also shared with you a report from the Autism Partnership Board analysing the data on the incidence of people with autism across Hampshire and the Isle of Wight, which should be of interest to board members. If we move on now to strategic leadership, health inequalities and risks. And Simon, I think you're going to present this.
That's correct, Councillor Fairhurst. I'll do the technical sharing just to make sure that works. I assume people can see that. Is that okay?
Yep. Yes, very clear.
Great. So we were discussing the issue of health inequalities, so I've pulled together a presentation for debate and discussion around the issue of health inequalities, and also really focusing on those risks and outcomes impacted by COVID, and based that on the disparities report. I've loosely based this on the kind of health wellbeing strategy to kind of talk it through, but also highlighted the ICS health inequalities work going on. So make sure we bring the two together and make sure we're clear as a board what our approach is. So this slide sets out what is in the ICS plan going forward about inequalities and the being really clear what they are and the avoidable differences in health across the population. And we know there's difference in health. And the ICS as a system, those bottom bullets there, have set out what they want to do. I think we would probably support those clearly in how we want to take this forward. And this presentation really helps us thinking about our particular strategy and where we need to focus our effort if we want to tackle health inequalities. As I said, I've been developing this over the last few days, so apologies you haven't seen this prior, but it is for discussion and debate, and I'm not suggesting I have all the answers. Just to be clear though, in our health and wellbeing strategy, we've been very clear about health inequalities as well, and we need to make sure we improve the health of the whole population and thinking about those wider determinants of health, which helps us move forward. So this presentation helps us with those aims of the strategy. I've got a number of slides with data on. I'll talk through and other people may want to chip in at the end and see if we want to take forward other pieces of data. I thought first of all that the thing that we look at in terms of inequalities is life expectancy, and just to point out there you can see the difference between males and females and the fact slightly different scales there, sorry about that, but really more importantly is when we look at the next slide is the difference, so the health inequalities gap. So you can see the gap between males is around 4 years and probably slightly less for females, but we can see that, so that's the gap between the most deprived and the least deprived, and so the age gap difference there. But if females are living longer, you can see the life expectancy gap of a poorer male and a more affluent female will be large. So just kind of that's the overall context, and actually if we put that in context, that's one of our aims, and we're trying to do that. If I move on to starting well, with respect to COVID, we haven't seen the impact on kind of child health in the same way we have for adults. So I focus on a few other indicators that we're clear on. However, we have seen some children experiencing poor, kind of different symptoms of COVID, but not to the same extent. So these small graphs, the top is the most deprived decile and the bottom is the least deprived. So you can see each one where I've picked out where we've got particular issues with regard to inequalities and what we might want to do about that. And they are indicators of issues rather than actually really to focus on the issue. So we've got population vaccination coverage. You can see there that we know that some communities don't have as good coverage as others, and that was the indicator I picked. Across the top, self-harm, again an indicator of mental health, and we can see in different groups that there's different outcomes to that, and self-harm is just the indicator, but we don't do so well here compared to the rest of the country as well, so we might want to think about that.
Simon, before you go on, is there any way you can enlarge the slide? The writing's quite small.
Is it not in full screen? Let me have a...
No, it's not in full screen.
Oh, apologies. Let me see what I can do. Bear with me, I'll unshare and see if I can share it a different way. Right, let's see if I can share that. Does that work better?
Not really. It's not still full screen. It's about a quarter screen, I'd have said.
Oh, okay. Mine's a full screen. That's not helpful. Okay.
I think, Simon, that just might be a system limitation. I think this might be the best that we can do. Maybe we will be adding this as a supplementary after. So if members want to review that after, that'll be fine.
So yeah, so we can see there that I realise they're small. So the top one was vaccination. Then across the bottom we've got obesity in year R, and we can see the most deprived at the top there. Under 18 conception rates, and then smoking and pregnancy, each an inequality issue that we just need to think about. And I think what I'm suggesting is, we do well on these indicators. Hampshire is a healthy place, but we just need to think about, does our approach need to change slightly if we're going to meet those needs? Now, I'm not quite sure which slide you can see now because of the way my, has that slide moved on?
No.
No, okay. I think because I've unshared, let me just unshare and reshare. No, I can't. Now I've got stuck.
No.
There we go. I'll see what I can do with that. So this slide hopefully gives COVID vulnerability indices, which looks at some of the vulnerabilities we've looked at in terms of COVID. So if we just move on to COVID going forward, and we'll look at some of the issues there.
Simon, I've still got your original slide up.
Okay, let's unshare and start all over again.
Mm-hmm.
Apologies, everyone. Bear with me.
That's it.
Great. Apologies. Right. So I wanted to talk through some of the issues identified in the paper around COVID. So we knew that age and sex was different. So we knew diagnosis rate was higher amongst females under 60 and higher amongst males over 60. However, when we think about the admissions and the outcomes, we know that is showing a different outcome. And we know that working age males were twice as likely to die as females. So we can see on that little graph the difference there. Something we just need to think about. There's no answers to this, but it's really kind of setting out a context. And it just said in the blue box that there were some differences, which may be due to different risk factors, and we still need to understand that and why that is. Obviously, we've got different situation in phase 2 with different treatments, but just worth bearing that in mind. And we heard a lot about ethnicity, but less about age and gender. We knew about older people, but maybe not the gender issues. So deprivation, we know that diagnosed cases, the least deprived group peaks earlier and lower in other groups. So it's interesting to see the kind of difference there. And now in the second kind of wave of COVID, we're beginning to see younger people being impacted first. Hospitalizations aren't in that way, but we're just thinking, what's the impact on the rest of the population? And we know mortality rates in the most deprived areas are more than double than the least deprived, so both males and females. So there's something about how do we support and work with those communities that are more likely to be diagnosed, have poor outcomes, thinking about that going forward. In terms of ethnicity and COVID, these two small graphs, you can't see them, the images are probably helpful in themselves. We know, I put a graph for black males and white females to show the stark difference that the black males are 3.85 times more expected deaths. So this is kind of excess deaths, whereas white females, that's much less. So something about how do we support those communities. And there will also be some lifestyle factors in there, maybe about obesity, but maybe about how these communities live and what we need to do to support those communities more. And there may be some genetics. So we're still trying to unpick that, but we can see the stark difference in inequalities. Then moving forward to comorbidities, we know that people with comorbidities, diseases of diabetes, hypertensive, chronic kidney disease, the list there, all had kind of worse outcomes or affected more. And I think we just need to bear that in mind, because actually these people are living with these diseases, and actually we want them to live full lives. And many people live with chronic diseases and live very well, but we need to think about how we protect those from the impacts of COVID if they're going to be impacted worse, which is what we saw. And then finally, a slightly different slide on ageing well, moving slightly away from COVID, but thinking about the inequalities. They will be impacted by COVID and other things, but we know that access to healthcare and thinking about chronological age as a barrier to treatment for various treatments is really key. And what do we think about that? And then where people live. So those older people living in disadvantaged areas having even less healthcare access than others. So I've tried to kind of summarize this presentation with something about young people at the beginning in our starting well, and I know we'll pick that up in our focus on that area. I felt it's really important this board had considered the disparities report and how that might impact on our population and what we need to think about locally, and then older people at the end as a key age group that we want to support, and the inequalities there that we just might want to think about. Apologies for the technological issues in the middle. I will stop there and happy to be part of the discussion on this item, Councillor Fairhurst.
Thank you, Simon. First of all, any questions? Alex?
Thank you. It wasn't so much a question as an additional comment, because I think the factors around age, ethnicity and gender for COVID have been very, very interesting. And I just wanted to let the board know that in the NHS, we have been doing risk assessments that have been getting more and more sophisticated on our staff, to the extent that if you're a male member of staff who is over 60 and who comes from a black and ethnic minority background, the restrictions on the areas in the hospital that we will allow you to go, and in fact at the peak time we were saying you need to work at home if you tick all of these boxes. So there's been a very sophisticated risk assessment profile which looks at a whole load of factors and underlying medical conditions as well. And then based on whether you're medium, high, medium or low risk, says you can work in a COVID ward, you can work in the hospital but not with COVID patients, or actually you need to work at home. And one of the things that's been quite interesting for us is that we have a number of our consultant medics who are in the slightly older male group, and particularly surgeons for whom working from home there's a limitation on what they can do. They can clearly do some outpatient consultations, but they can't do the surgery that they love. And we've had quite a few interesting conversations where people have said, but I want to be at work, and we've had to sort of juggle the actually you are too high a risk to yourself, and can we find other useful things for you to do for the period of time where COVID is more of an issue. So those factors that Simon was describing have really played through in a very real way with our staff groups.
Thank you for that, Alex. Anyone else? Christine. Christine, can
Sorry.
you?
Yes. Yeah. I got some messages from the team at Healthwatch that they'd like to contribute to the discussion. And I can send you the links that they've sent me if that would be helpful. But they made 3 points. The first was that they understand that looking at excess deaths, that there's been a high level of excess deaths in care homes that hasn't been related to COVID-19, but they also absolutely understand that that's being looked at. And they wanted to say that they continue to support the council in understanding how that's happened and want to work with you, and have sent a little bit of information. The second thing was that they were interested in the effect of the move to digital on inequalities of access. And they're trying to have more conversations with the people whose health inequalities might be exacerbated by the move to digital, and are exploring how they can further this work. And they've sent me a link to some of the stuff that they've done already on that. And then thirdly, the problem with unpaid carers, who their information is that they're reporting increasing issues about lack of support and trying to cope. And they've just begun an extensive piece of work in collaboration with unpaid carer organisations, hoping to identify what the issues are and identify what support would help them. And again, I'll send you the link. Thank you very much.
No, thank you for that, Christine. And I've got a little note here saying there's 13 hands up, but Simon, you're the only one I can see, so would you like to speak?
Oh, I'm not sure if that's a presenter privilege. And Alex, it's really interesting to hear what you're doing around staff groups and how we then think about that for our populations in terms of going forward, because I think that's a really practical step you took and realistic with staff, but we need to think about the rest of taking a population approach and how do we build that in. And just moving on to Christine's point, I think excess deaths, we need to look at that over a little bit of a longer time period. We did see the excess deaths increase during COVID, as you would expect, but what we need to understand is actually, did those bring some deaths a few months earlier than we expected? So actually over time, we haven't seen excess, because excess deaths are right down now, and absolutely looking at all excess deaths, not just deaths from COVID, really important. And I think you're right to think about inequalities in terms of digital. And I know when we ever think about digital, we don't think of it as the answer to everything. It's one of the solutions to increasing access for some groups, and what do we need to do to make sure that we don't restrict access for other groups. And carers will be one of those groups we need to think about, and the impact on their income and their ability to access health services. So really key issues we can pick up. Thank you.
Councillor Fairhurst, you're muted.
Sorry, I knew it happens to me as well. Matt Nesbitt, did you have your hand raised?
I did have my hand raised, and really it was just to say that I think Christine makes a fantastic and really interesting point. I mean, I think healthcare has changed more over the last 6 months than it probably has in the last 20 years or something. We're all delivering things very differently, and it would be really interesting to understand the effect that that's had on inequality. Some of the patients that I look after don't have cars, so getting to the surgery is very, very difficult. In fact, getting anywhere is very difficult. But understanding whether or not increasing digital access had improved things for them would be really interesting. So I'd be really interested to see the work that you've done, Christine, and interested to see any work that Public Health were doing on that too.
Thank you. Christine, you'll share the results of your studies with us. Brilliant. Councillor Manns.
Thank you, Liz. I just really want to make a very quick point following up what Matt said and others have said. If we are going to use things in a more digital way, it's vitally important that people have good Wi-Fi connections. And I'm on a crusade at the moment to ensure that every new dwelling in Hampshire has fibre optic cable to the front door. I've gone into a discussion with government about this through the planning white paper, and I'd very much appreciate support from this particular group, precisely because of the point that Matt has just made. If we are going to get to those more deprived communities, they must have the decent Wi-Fi. It's the same way as you would not expect a house to be not connected up to the water supply or the electricity supply. In the modern digital age, it needs fibre optic cable to the front door. So that's the speech I'm making on every occasion I get the opportunity of doing so, because I really think it's important if we're to actually, otherwise we will have pockets of the community, particularly in rural Hampshire, that will be cut off completely by most of the things they'll need to survive in the modern age. Thank you, Liz.
Thank you, Councillor Manns. Graham, you wanted to come in.
Yeah, thank you very much indeed. I'd just like to, I think, follow up on a few of the comments that Christine made in terms of questions, but also work that's taking place, and then just to also say a few more additional things, if I may. So firstly, that point around non-COVID deaths, particularly in care home settings, is a critically important issue to understand. As Simon says, we will need a little while in terms of getting under the skin truly to understand. So repeating myself from information recently shared at the Health and Social Care Select Committee, over the peak of COVID through the period March through the end of July, we saw approximately 330 excess deaths that weren't directly attributable on the death certificate to COVID. And of course, there'll be lots and lots of different factors at play there. Through the auspices of the Hampshire Safeguarding Adults Board, we've commissioned a piece of work with health partners, Health Watch being included, and others to understand that. And at the point that that report is available and ready, I'd like to make that available clearly to this board, because I think it's a critical issue. The second thing to say is in regard to informal carers. I've seen a report circulated this morning. I haven't yet had the opportunity to read it in any detail, but it's suggesting, again, over the peak of COVID through the period March to July, up to an additional 92 million hours of unpaid care was provided to people with support needs. So that will be coming from family, friends, neighbours, and indeed other acquaintances, but it's a truly astounding amount of time that's been provided to support people across communities, and that's England wide. So that's not a Hampshire figure, 92 million. That's a national figure, but again, something truly quite astounding on top of the unpaid care hours that were already being provided routinely. I'll circulate that report through the notes of this meeting, Councillor Fairhurst, if that seems appropriate. And then finally, it's a comment really around access to services through digital means. I think one of the critical things for us as a board, notwithstanding comments that Councillor Manns and indeed others have made, is that what we've got is a potential for some people to be digitally excluded. And I think for us, the antenna need to really be twitching, both in terms of people that might be digitally excluded, but also given the other information that Simon has covered in his report this morning, in terms of particular areas or pockets or communities where deprivation may be a more significant factor. So there's a huge onus upon all organisations to make those connections with a whole range of other partners, some of whom are on this board and others not. So I'm thinking, for example, Department of Work and Pensions. And we know that frequently for people in older life, there's a reticence to sometimes claim the benefits to which they're entitled, which will then impact further on deprivation and so on and so forth. So there's a huge amount of dots that we need to continually be joining up. Thank you very much indeed.
Thank you. Alex, before I ask you to speak, Councillor Manns, can I just say Councillor Perry in the chat room has thus thoroughly endorsed everything you've said. Thank you, Graham. Alex, did you want to come back on something?
Sorry, yes, I just wanted to come back on the digital exclusion thing, because I think it's been really interesting. We, as many of you will know, have been running engagement events through June, July and August about our Hampshire Together programme of changing the way we provide NHS services in Hampshire. And we've done it all over Zoom. And while we've recognised there are some people for whom that doesn't work, we actually, when we look at the number of people who have engaged and listened and given us comments, we have a broader representation of people with disabilities, of people of all ages, from young to old, of people of our whole geography, than we have had in previous similar events, which we've been doing in real life, face to face. So I think when we were holding things face to face, we perhaps didn't think so much, or, you know, we tried to think about people who couldn't physically get to events or whatever. But actually, I honestly think that through the digital mechanism, we have reached a broader population than we have done if we've tried to do things purely in physical space. previously. So I think it's really, really interesting, and I think this is a very much an evolving picture. There clearly are some people who are digitally excluded, and we need to do a mixed model. But I do actually think sometimes the digital revolution that we're going through is actually enabling some people who could never have been involved before to get involved now.
Right, thank you, Alex. I think I've got...
Sorry, I was just going to say Dr. Rushton has had her hand up for a while. I'm not sure if you can see it or not because we've had some hand issues, so just wanted to point that out.
Thank you, Samaya. As I say, I've got 14 plus hands up at the moment and I can't see any of them.
I don't think that's correct, so we can call them out too if that would be helpful to you.
Okay, after Barbara, can we have Dr. Bibaway? Yes, because I can see that his hand's up. Barbara.
Thank you, Councillor Fairhurst. So several points really. I think from Simon's presentation, it's very clear that there are a large number of rather hard to reach groups that we really will need to concentrate on because of their excess risk to COVID. And some of those are, as he said, deprived, and some of them are from different ethnic minorities. And sometimes it's really difficult for us to prioritise where we can affect change. There are some risks that are undoubtedly modifiable. Some of those will be around treating people with diabetes or treating people with cardiovascular risks. But some of those are modifiable by people themselves, and getting the message out to those hard to reach groups is quite tricky. And I'm hearing from around the country that some of these people, particularly from ethnic minorities, are becoming quite suspicious and finding it really difficult to take on board their excess risk. And so to do that, to help them and to support them with an ability to understand their reticence is going to be important. I think the digital bit that has been so widely discussed already is so helpful for access to care, in that actually all of primary care, all of your practices, your surgeries are now open and have remained open throughout the pandemic to date. But of course they're open because they are actually doing a total triage system, and I'm not sure how widely understood that is. That doesn't mean to say it's more difficult, it just actually makes it very much easier because it's quite possible for people to fill in an e-consult from their surgery website and ask for help and support, and that to be then directed to the right member of the team. It's still very possible to pick up the telephone. What it's not advisable to do is to actually go and visit your surgery without calling first, so that when you do need to be seen face to face, it's perfectly possible for a proper appointment to be arranged in a safe place so that it's safe to you and safe to the staff. And just in reference to what Alex was saying about the staff in the hospitals, similarly, the staff in primary care have been risk assessed, and some of them, of course, will have to continue to work from home. But that's been enabled because of the ability for them to work digitally and to do video consultations and to do telephone consultations and still have access to a patient's record. So I think it's really, really important that we spread the word about access, because actually although it's different and although it will have to remain different for the safety of patients and for the safety of staff, it is all open. And actually, we're doing really, really well. We're doing really well, for instance, in collecting people who may need to have a diagnosis of cancer excluded within 2 weeks. So actually, we're keeping up well ahead of the game there around in comparison to the rest of the country. And it does appear that people are able to come forward and aren't too frightened to come forward. Although initially, I think there were reports about people with heart attacks not coming forward. They are coming forward now, and they must continue to come forward as the pandemic increases again.
Thank you, Barbara. Dr. Bibaway?
Thank you, Councillor Fairhurst. And so I'm not going to repeat a lot of the really good points said. I just wanted to kind of just agree with Graham around the digital access inequality that I'm currently seeing in primary care, particularly around those not very digital savvy, and whether, you know, obviously we do have e-consults, we do have various ways of entry to primary care, but I am seeing some avoidable non-COVID related late cancer diagnosis just on that very point. And I'm not sure if we're able to pick those up separately and focus a little bit about the digital access and how that's created that inequality and how we could work together collectively on addressing it. I see it as a problem that is going to get worse. We know that a lot of our patients have, you know, just generally have different thresholds of accessing medical services. And I just think that digital platforms have exacerbated that to those who don't or won't necessarily access them early on. So just agreeing with that very point, and just would like to see a collective endeavour to see how we can address that. Thank you.
Thank you, Peter. Samaya, is there anyone else?
Dr. Rory Honey.
Ah, Dr. Honey. Thank you.
Thank you very much, Councillor Fairhurst. Barbara described very eloquently, I think, the issues around modifiable risk factors and ensuring none of our communities are left behind, and addressing risk factors like smoking, obesity, diabetes, cardiovascular disease. It doesn't only make our population more resilient to COVID, but healthier and more resilient, full stop. I think just one note of caution is when we drive forward our already very good efforts around disease prevention and preventing ill health as a system, it's important to make sure that we don't rely too much on individual responsibility, because that can sometimes exacerbate those existing health inequalities. And as Barbara says, you either need to provide lots more support to certain communities where just making equity of access enough, it won't be enough. You'll need to try and look at vertical equity to really help bring everyone up to the same level. So it's just a flag that sometimes individual responsibility as an approach could inadvertently exacerbate inequity rather than do what we're trying to do, which is reduce it.
Anyone else? Anyone else got their hands up? Simon, you want to come back?
I was just going to kind of come back on some of those points and say absolutely it's really helpful to have a really good debate here. And I think as Graham said, he's looking at the review of kind of care homes and the deaths in care homes, and we need to think about how we take on reports such as Graham's and think about how, you know, he'll be looking at inequalities and what's going on there, and how do we do that in all the pieces of work we look at as a board, and support and challenge each other to unpick some of these really difficult issues as Alex develops the approach in North and Mid with healthcare. How do we really make sure that we support each other to think about inequalities? And saying that, we will be, as you'd expect, refreshing the Joint Strategic Needs Assessment in light of COVID to make sure that this board and others are fully aware of kind of changes in need and any inequalities issues. So that is an ongoing piece of work. I've already shared some stuff previously via email, which we'll continue to do as we get more information going forward.
Thank you, Simon. Matt, did you say you wanted to share a graphic with us?
Oh, I think I have done. It's just a picture that shows what primary care has achieved across Hampshire and the Isle of Wight on a single page of A4 kind of thing. So I've put that in the chat.
Ah, okay. You couldn't put it up on your screen, could you?
Oh, I can try.
Members, can I just remind everybody, while using the chat is helpful, it's not transparent for anyone viewing the meeting, so they will have missed any of those pieces. So if we do, it would be preferable if you were to share it by raising your hand. Thank you.
Oh, sorry. I didn't realize other people couldn't see that.
Oh, yes. So the webcast that we share, everyone will be able to see the screens that you see, but not the chat function.
I don't think I can share it because it says only meeting. Oh, maybe I can.
I can circulate it after the meeting as well, if that's helpful.
That would be good, Samaya. Thank you for that, Matt. The board members at least will get it circulated. Oh, there we are. Right.
Is that? Can you see that maybe?
Yes, absolutely. Yes.
Oh, I can't make it fit the screen, but anyway, we can circulate it afterwards.
Yes, that would be very useful. Thank you for that. Right. Any other comments from anyone? Right. Shall we just have a look at the recommendations then? And thank you, Simon, for that. Thank you very much. The recommendation is to note the inequalities and health and well-being impact of COVID-19 to the residents of Hampshire.
Thank you, Chairman. Do you want me to lead on? Do you want me to lead on this? Thank you.
Yeah. Okay. Off you go, Jeff.
Can I just check, does anybody wish to abstain from voting? No. Does anyone wish to vote against the recommendation? No. I therefore take it as unanimous in favour then.
Thank you, Jackie.
Yes, that recommendation's carried. Thank you.
Thank you. We're going to move on now to Children's Services update on COVID response. Steve, are you doing this?
I think it's going to be Suzanne, Councillor Fairhurst.
Suzanne. Yeah, okay. Suzanne.
So, sorry, my machine just broke at critical times. I was here. So.
Good.
So can I just introduce this? And Suzanne's going to do the presentation. But in the notes, it does say that we receive an update on priorities and progress of the Starting Well strand and the impact of COVID-19 on the progress in this area. So what I would quite like to do, if it's okay with you, Chair, is very briefly give you a verbal update on COVID-19 as it pertains to Children's Services, which will give you a bit of context in which you can then place the following presentation. Does that make sense?
That sounds good, yes.
Okay, so just to give you a little bit of an update then, firstly, in terms of children's social care services, and we have always been very clear that the challenging period for us would be when schools came fully back into play, and we would expect to see a lot more referrals into our children's social care service. Well, in fact, that has been the case. We were relatively quiet in March and April, as you might expect, when there were few children at school and there was complete lockdown. Those numbers started to go up in May, back to more or less normal, actually. They went above our normal level for the time of year during July and August, and that has continued through into September, including 1 week in September that was very, very busy indeed, 60% above our normal referral rates. That felt like it was the schools sort of getting in touch with everybody that they'd been concerned about. But our general level of referral is about 10 to 15% above the normal for the time of year. So that's the level of workflow, if you like, that's been brought about by COVID. Not no specific reason behind it, but what we are seeing is evidence of more families experiencing sort of traumatic family breakdown. Often those families are not ones that we've ever had contact with before, and being affected by either unemployment, substance misuse, a range of factors, but has led to family breakdown. So we're seeing some really quite complex and difficult stuff at our front door. The services are holding up very well, and we're very robust. We're seeing about 90% of the children at any one time are being seen by face-to-face methods. We're still doing some online stuff with some children, but we're making sure that we get round to see those in person as well. But most of our visits are in person now. Our work with partners, both NHS and police in particular, continues to be strong. An irony, and we've talked about it in other contexts, but the new technology has given us more ways by which people can contribute to child protection conferences and so forth. So those are going very well at the moment. We've got an eye on sickness rates and so forth. It's been very good so far, I have to say. Very few people have been either off sick or self-isolating, but we keep it under constant review in case we need to move people around the system to cover gaps, but that's been okay. In terms of education, again, people have seen the various bit in the press over the summer. I won't really comment on GCSE and A levels. That's, you know, you can read and take your own view on that. Most importantly for us has been getting children back to school in line with public health advice, and that's been going extremely well in Hampshire. The national average in terms of the numbers of or percentage of children in school is about 88%. We're coming out in secondary about 92% and in primary 95%. Those figures are going up actually almost by the day. So we're above the national average and really working hard to make sure that children getting back to school. That means inevitably that we have to do case management when there are positives, and we're running at about 5 or 6 a day where there is a positive diagnosis of somebody connected to the school. And every single case we work with the school on with public health advice about who needs to isolate and so forth, and we put that into place with the school, and that seems to be working pretty well, I would say, at the moment. We've got a sort of a bit of a worry about how this rolls out in special schools, in particular when there is a case and we find that more people have to isolate then. So that's an issue, but I don't think it's an avoidable issue, if you see what I mean. And then moving on really to other areas, early years sector has held up well. We've got a good match between supply and demand at the moment. There is sort of latent supply, so early years providers could provide more, but they're matching it to the levels of demand, and that seems to be working pretty well, better than we'd anticipated actually, I think. So those services have bounced back is how I would describe that. And then finally, the other bit of the jigsaw for us was homeschool transport, which we commission. That was very, very difficult for us and many authorities, or many large county authorities, where the guidance for homeschool transport was received by us on the 12th of August. That's too late, and we had to change all our commissioning arrangements and so forth, and that meant that the beginning of the term was quite difficult for some parents in terms of getting all the right buses lined up and so forth. So, but that's settling down now, but it wasn't helpful, to be honest. So that's where we are in terms of the sort of COVID response in the round. If I now hand over to Suzanne, and she's going to walk you through the starting well priorities that we set for ourselves and where we are on those, and hopefully they'll make sense in the COVID context. And I can see that Judith's got her hand up. Do you want to take that now, Chair?
Yes, Judith, do you want to quickly go in?
Yes, thank you. Specifically on COVID and the response, Mr. Crocker said that there are families becoming known to us who haven't been known to us before, and I thought he might want to say a few words about the Supporting Families programme, which is continuing to engage with families and new families this year. And the special COVID emergency grants that were made to help people in specific areas throughout the county. And of course, you know, the Supporting Families programme means that early intervention hopefully will avoid more significant intervention further down the line. And also perhaps something that I know has been concerning people is support and education, if I can put it that way, for staff in schools to deal with potential mental health issues following COVID on the return of students to schools. Thank you.
There's a lot there. So early intervention, one of the issues that COVID presents us with is that families are either not, because universal services have not until September been in place. We've had fewer collective eyes on children. So that's why we are seeing families that have basically short-circuited and not got the support that they could have had through supporting families or other early help services, and are coming straight into the system. But at the point at which they're coming into the system at the moment is not, they're not coming in at early help. They're coming in with children who have been seriously harmed, and without ever touching the sides of the preventive services. Now, what we are now in is, because schools are back, because nurseries are back, what we anticipate and are seeing is that we're now getting those referrals in for families that can access, so we can get them into early help services, we can get them into supporting families, so we can now get that back up to the levels of referral that we need. But without a doubt, and there is a whole cohort from probably April to August who've come into the children's social care system who didn't touch the sides, if I can put it that way, and some of the things that our social workers have had to deal with have been really quite distressing, in terms of some of the harm that's been caused. So that will get better. We're confident about that. But the very nature of it is that it relies on universal services to identify families that need early help. When they're not there, they can't get it. The other question was about schools, and there is a government-funded programme to support teachers and school staff in helping pupils with who are returning to school with emotional well-being issues, shall we say, who might need support. It's an interesting one, though, because it isn't quite playing out as we might have anticipated. There are quite a lot of children who say, actually, last 6 months has been fine, thank you very much. And it's not quite, so we're not having to deal with that much in terms of repair, in other words, repairing trauma. But what we are having to deal with is perhaps more about anxiety about returning back into school full time, which is a slightly different thing and a slightly different worry for children. So that's where we're working with schools. We have a whole series of training programmed in for this term, being rolled out to all of our schools so that they've got a better level of understanding and can signpost children to the right support as and when they need it. And that also goes hand in hand with, at least in the southeast of the county, we've got we've had a successful bid to the NHS around additional mental health support in schools, and ultimately we anticipate that will roll out across the county, and it's a matter of timing, but they're doing it bit by bit. So we've only got that really in the southeast of the county just at the moment. Well, I think I've covered everything, Councillor Greski, is that right? Yep, thank you. So
thank you, Steve. Yeah. Okay,
shall I hand over to Suzanne then, who'll give us an overview of the priorities that we've all agreed around working well and where we've got to on those.
Thank you.
Thank you.
Starting well.
Can I just confirm, do you want me to share the slides, or Tamara, is that something that can be done from your end, or would you like me to do that?
Suzanne, if you could share it, that'd be really helpful as I'm doing minutes. Thank you.
Yes, bear with me while I just put the slides on the screen. I don't know if others are having the same technology issues as me today, but the systems are quite slow. So. Right, sorry, I'm getting a message, can't display content.
I can have a go, Suzanne.
Thanks, Steve. While Steve gets the presentation, I'll just give a brief introduction. So we were scheduled to bring an update to the Wellbeing Board back in March on the progress of the Starting Well chapter of the strategy. Obviously, COVID happened and other things came to the board, quite rightly, but just to remind ourselves that the aim of the Starting Well chapter is to improve the health, happiness and achievement of children and young people by working together to reduce inequalities and improving outcomes through greater collaboration. So that's the aim that we're working towards. And underpinning the strategy is an action plan, which is the subject of this presentation, which we've updated just to include some context around COVID and the impact that it's had on our ability to deliver against that action plan. So I'm going to present today alongside colleagues from Public Health and from the CCGs, because we all have a kind of key part to play in delivering those actions. And we'll go through slide by slide and we'll pick up different pieces each. So the next slide, Steve, just gives us a reminder of the actions that we identified for ourselves, the priority areas that we wanted to work on. There's a wealth of information in the pack that you've got around each of those priorities and what we're doing, and the intention today isn't really to go through every line of that, but to pick up on key things and then answer the questions that you might have. So with kind of no further ado, I'll hand over to Simon, who's going to pick up on the first priority, which was around emotional health and wellbeing strategy recommendations.
Thanks, Suzanne. Yes, so we've had a number of, we talked about mental health earlier on this morning, and Steve mentioned the kind of impact of COVID. So this slide really sets out where we are and what we're trying to achieve. So thinking particularly about self-harm and mental health conditions to bring Hampshire in line with England. And you can see on the right-hand side of the slide a number of things we've done. So we've launched our emotional health and wellbeing strategy, which has a number of actions beneath it, including a self-harm toolkit. We've done a school survey to really help understand at a school level and a Hampshire geography the key issues that we are needing to understand, both of pupils and of teachers, really important. And as part of that, we've launched the Health in Education Settings website, which provides resources, training for those teachers. And then obviously, and you can see there that as Steve mentioned, COVID challenges have been wide and numerous, but particularly the issue of young people's mental health, which isn't as uniform as people might think. So as Steve said, many different issues to pick up there, but the work's going well. We have had a stubborn target on self-harm for many years, and we need to really grapple with mental health conditions, not only in this sense, but actually how we work with CAMS as well. I think I'm handing back to Suzanne now for the next one.
Actually, we're going to hand over to Anna, who's going to pick this one up, and I think she also wanted just to bring in some bits around CAMS.
Thank you, Suzanne. Thanks, Simon. I just wanted to pick up on the 4 points really at the bottom of the previous slide, which were the focus of the CCGs and the rest of the system around some of the issues that we're currently tackling, specifically around COVID, but wider issues as well. So we are working really hard to confirm additional investment into our CAMS services to work on reducing access and waiting times for assessment and treatment, which you'll all know have been high, unacceptably high for far too long. We are working with our acute setting colleagues, so across the hospitals, to develop paediatric psychiatric liaison services. We are looking at bolstering our prevention and early help models, helped with the mental health support teams in schools, which I'll come to talk about in a minute. And we're also focusing very much on various elements of the NHS long-term plan for the coming year. So yeah, if you could take it to the next slide, please, Steve. So this is really touching on what's already been spoken about in terms of mental health support in schools. So we are lucky in that we've been successful in securing investment into 2 mental health support teams, which are in Havant and Gosport. The teams have been recruited and are starting delivery within those schools in January. Unfortunately, we were not successful in 3 further bids to have mental health support teams in schools in North East Hampshire, Farnham, North Hampshire and West Hampshire, but we're working really hard to bring in young people and family voice to strengthen those bids, which we'll put in again in January, because those were the elements of the bids that were missing really. So our work with young people and families has to be much stronger in order to bolster those bids. We are also working with the Anna Freud Centre on delivering a county-wide programme called the Link Programme, which is focusing on developing relationships between mental health services, education and voluntary sector staff to improve what we're doing in our schools. Next slide, please. And then just in terms of how we're using technology to support young people, we have got a number of things in place at the moment, but I think what I'd like to highlight is that we want to explore in partnership with young people what sorts of digital support and interventions would work best for them in order to have a flexible offer to meet different needs. So we recognise that our work here has not been particularly good, and individual services have done a lot more to move this forward. For example, CAMS, who are exploring a number of different digital options and solutions to complement face-to-face therapies and interventions. I think previous decisions regarding digital work haven't particularly taken into account the target market. So we really need to think about how we work with young people to meet their emotional and wellbeing needs via digital technology. I think that's probably it for me. Thank you.
And I think I'm picking up the next few slides. So if we move on to physical activity, and we'll hear from Julie Amy's later on, but we've done some really good work. And our schools survey has been really helpful because for a number of years we haven't had a survey nationally. The surveys all stopped. So we've really tried to understand our physical activity needs along with the number of other needs. And we've now got a really strong partnership approach to supporting PE in schools and also physical activity in general in young people, and a joint strategy with us and Energise Me is a really positive way forward. And you can see some of the work there, but we need to think about the impact of COVID on physical activity levels. The next slide sets out some work we're doing and the priority around smoking in pregnancy. As I mentioned earlier in the inequalities piece, that a key area for us. Steve, I don't know if you can move on or if it's just my slide that's stuck. And working with the local maternity partnership is really key. We do need to make sure that we continue to focus on inequalities in this area and make those referral pathways really strong so that every woman who is smoking in pregnancy and then every father also has the opportunity to give up smoking for the health of their child and themselves. And we did have new CO monitors, which are a really good tool to support people to have that conversation, which were embedded in all maternity services, and that's been slightly challenged by COVID due to the infection control issues we need to be mindful of. So we are working through that and some really good work there. But we're seeing a steady, slow reduction, so that's really positive. The next slide highlights some of the work we're doing around breastfeeding, again working with our maternity services to increase our breastfeeding rates, and Southern Health, who are the provider of the health visiting service within Hampshire, are working towards baby-friendly UNICEF gold standards. So that's very positive, and we need to, and our rates are in a good place, and we've kind of done lots of work to really understand that and make sure we can continue to support mothers to breastfeed their babies. I'll stop there and I think I'll hand back to Suzanne now.
So I'll pick up around the kind of co-design and collaboration piece. We've got a history, I suppose, about, amongst partners of working really well together, but not always consistently and not necessarily in a timely way. And so one of the things we chose to focus on kind of early doors with this action plan was around getting an effective joint commissioning board in place, looking at how we use that between the agencies to agree the kind of strategic commissioning priorities that we feel are beneficial for us to work on together. And that joint commissioning board has been in place for around 9 months now. It was picked up during the SEND inspection and we received some positive feedback, but one of the actions arising from that was the need to formalise our work into a joint commissioning strategy, and that draft is now kind of in circulation, as just being refined by partners. We're doing good work together around mental health pathways. As you would have expected during lockdown, there were other priorities that meant that some of that work was placed on a back burner, but I think it's fair to say that all of those things are rising back up the agenda, and we're kind of more into a BAU kind of business as usual way of working and working through how we want to improve those pathways at the moment. We've also brought the Isle of Wight into our joint commissioning board, and so we're operating across Hampshire and the Isle of Wight in those arrangements. The next slide, please, Steve. The next one is kind of building on that, I suppose, but particularly focusing on continuing care, which was an area that we've had in our sights for improvement between the CCG and Children's Services for a number of years. We have set up a multi-agency resourcing panel to provide a decision-making body and forum around continuing care, and that's been hugely successful and is embedded now with all partners, and is leading to much more timely decisions around continuing care packages and more effective kind of joint commissioning. And we're starting to see that feed now into our joint commissioning strategy, where we're starting to consider how we might manage some of the care support markets kind of collectively together rather than having separate arrangements. I think that the work never stopped in this area during lockdown. It did slow, and as you'd imagine, a number of packages remained fairly consistent during that period. But again, very, very quickly ramped back up, and I would say that we're operating as normal around those panels. We're also kind of moving towards how we take kind of the next step with that. So how we develop a kind of different approach to how we fund those packages. And I think the next slide takes us into some of that. Oh, no, it doesn't. Sorry. So I'll just pick up. So I think we're starting to develop. I think one of the things we've picked up on is the lack of pool budgets between agencies. But the work we've done through the multi-agency resourcing panel is kind of the first step towards maybe starting to consider how that might work in the continuing care space. So that's a development that's yet to come. So moving on, the next priority that we had was around working with partners to build resilience in children and their families. And this is a kind of key tenet of Children's Services Transforming Social Care programme, where we're looking to keep children safely at home wherever possible, and key component of that is building that resilience in families. We've put in place some really effective multi-agency specialist workers that form part of that team around the child and are working through the kind of virtual hubs that we've got in the districts across Hampshire. And the impact that was having was really evident. As Steve says, the numbers of children coming into the social care system are now rising, but it's fair to say that those interventions are still effective, and we are still tracking and able to show that way of working, where we've got those specialist substance misuse workers, domestic abuse workers, alongside social care staff, is really proving to be effective. We need to look at making sure that we've got a kind of sustainable funding model for that for the future, because it's definitely something that we don't want to lose. And it would be fair to say that whilst lockdown prevented, or there was a period of time where there was more virtual working, as Steve's already outlined, we're back to face-to-face working, and nothing stopped in that space. One of the challenges we'll have now is how we meet that rise in demand as it starts to work its way through. Simon, I think I'm handing back to you for the next one.
Thanks, Suzanne. I think you covered some of it. So we've done some really good work around substance use and domestic abuse. Our substance use service to children and young people now goes up to 25, so that transition issue is covered. So that means someone who's 20 or 21 can either go into the adult service or the young people service, but they're one service, so the work is working really well together. And we have some good family recovery workers within children's services looking at substance use and domestic abuse, and also thinking about our service kind of going forward in substance use. We are working through the increasing demand for services for young people, which may be related to that kind of older age group we're seeing. So we just need to keep an eye on that and support that, and provide more training for staff on substance use, and providing domestic abuse risk assessments. So all going really well. We were impacted by COVID, as Suzanne said, in different ways. So some services were more digital, and other services were running as normal, but very challenging. And like children's services, seeing that increase in domestic abuse now being more highlighted due to people backing more universal services such as education.
And then finally, in terms of the priorities, we had one around really looking at the successes that adults health and care have had with their technology enabled care offer, and how we can learn from that and replicate an offer in children's services. And we did some really good early work around how tech could form part of a residential care offer. And we have a number of families using or having a technology enabled care package in place, but we think there's more we can do here. I think COVID definitely did have an impact here, because our ability to work with families and build their confidence around technology forming part of a care package was quite difficult, particularly where a number of those children were in kind of shielded groups or particularly vulnerable. But it's definitely something that we've done some good kind of baselining work and some good testing of the different things that are available. But what we now need to do is make sure that our social care teams really understand what's on offer and what part it could play in a care package, and that we also work to build confidence with families so that they don't just see it as a money saving thing, they actually see the benefits that it can offer them. And we've got some fantastic case studies and advocates through the likes of Hampshire Parent Carer Network who we can work with to get those messages out there. So that kind of brings our presentation to a close in terms of where we're at in terms of delivering on those priorities. Steve, as chapter sponsor, I don't know if there was anything that you wanted to add or comment on, and if not, we'll go to questions.
That's fine. I think you've covered it, Suzanne. I'm very happy to go to questions. I'll stop presenting now if that's all right for everybody, because I can't see otherwise.
Yes, no, that's fine. Thank you both very much. I think there's an awful lot of positives there and some really good work going on. So well done. Can I? Sumaya, who's got their hand up? Because I can't see anyone at the moment.
I don't see any hands up yet. Members, do you have any questions? If you could raise your hand or type RTS in the comments.
I can see we have Nick Tustian.
Nick.
Yeah, thank you, Chair, and thank you for that very interesting presentation. And I have to say, this is the point I've made before, and I maybe have missed this throughout the whole of the presentation. And I reflect on the work that's going on at district councils through the Health and Wellbeing Board in and around some of the healthy eating programmes, thinking around things such as breastfeeding clinics. I also reflect on all the work that's going on around physical activity, particularly through leisure centres, through the youth programmes that are there. What I don't see in any of the presentation, we talked a lot about joined up working, is the reflection of what's happening at district council level and how we can join up initiatives much more effectively across the whole piece. Now, it may be that it's in the subtext somewhere, that it's in the detail that there has been or is extensive liaison with district councils working on joint programmes together, but that doesn't come through in the presentation. And one of the things we've been sort of always pleading for, certainly as part of the district forum, is a lot more of sort of direction coming through this board, so we can start to join up initiatives across district councils, work in the district council forum. And I just, again, don't want an opportunity to be missed in that a lot of what districts do around its health is around the preventative stuff. And that runs right the way through the whole strategy, not just in starting well, it's living well, right the way through. And it just feels again as if the role of district council has perhaps been sidelined in this work. And I think there's a lot more that we can get from it if perhaps districts were better joined up with it. Now, I may be, I say, missing it, but it just doesn't come through to me that districts are heavily involved as I think they should be throughout.
Yeah, can I come back on that, Chair? I think it's a fair challenge, and you hit upon it in that there is a sub text to it, in that we're currently doing a significant piece of work through Suzanne's branch, Hayley Maspero's leading it, around the way in which we link up our preventive services at a district level. And at the moment, for example, one of the issues is that we've got in every district, although it doesn't quite cut exactly the same, we've got a troubled families steering group, we've got an early help hub, we've got a local children's partnership, we've got a community safety partnership. Now, those four groups are often covering some of the similar territory, and the piece of work that we've got underway, which is due by the end of the year, is just what can we do that would perhaps reduce that down. So I think it's a fair challenge, but we haven't put it in this presentation because it's not ready yet, if I can put it that way, to come back here but I think it will lead us to a more coherent approach district by district, which would entirely encompass those early intervention activities that you've referred to, Nick.
Chairman, if I may, I might be able to help slightly in this, and members may not be completely cognizant of the fact that Hampshire County Council has actually part paid for a district level health and wellbeing coordinator, which is actually hosted at Hearth District Council. We pay for the rest of it. And so to help Steve, I mean, essentially, we are the ones who are holding that relationship at the district level because we've got coordination there. There's a lady by the name of Rosie Fowler who actually works to North East Hampshire and Farnham CCG, but she's seconded across to us. So I think there's an opportunity there to not overcomplicate this and actually use some of the resources that are already available to make sure that we're linking in really effectively into all of those respective streams. Because as Nick has said, there is so much work going on at the district level that needs to be included and reflected in the broader spectrum of the system that we're working within.
That's absolutely right, Patricia. And my issue, and it's not a problem in and of itself, is that every district will look slightly different in this regard, and we definitely don't want to overcomplicate it. What we want to do is try and simplify it and get to a more coherence. So that's work in progress.
Thank you for that, Patricia. Simon, you wanted to come back.
Yeah, and just to add, so one of my teams sits on all the district health and wellbeing boards and has a district link for the areas that are probably not so close to Steve's areas, such as physical activity and those kind of things. So we are working really closely with you. I think COVID has knocked us a little bit sideways in terms of resource, but we're, as Patricia says, working with Rosie and others to make sure that those kind of more public health priorities equally are embedded in the districts. Some really positive work in Rushmore around obesity, working with Peter Bibway and others. So there is lots going on, as Steve said. It's just quite complex, and we'll make sure the work is tied together at a county level so we can give a consistent input.
Thank you, Simon. And anyone else?
We have Councillor Philip Raffaelli. Apologies if I've pronounced that wrong.
Philip. I think you're still muted, Philip. I can't see Philip and I can't hear you.
Yeah, I think that might be me now.
I can hear you now. Yes, sorry, carry on.
Oh, yeah, no, sorry. Yeah, I would actually support what Nick was saying, and I'm delighted that there is work to coordinate and bring it together, but I'm very sympathetic with what Steve says about keeping it simplified. I think that's going to be essential, but I'm delighted about that. But if I could go back to the presentation, there was just a couple of things. I'm delighted that Gosport's got one of the 2 mental health support teams, and it's on schedule to kick off in January. You also mentioned the school ambassadors. Do we know where they are, and do we have any in Gosport that we could begin to link in with? So that would be my first question. Then the second question was about the Ninja Self-Help app. Has there been any feedback on how well that's being taken up and responded to by the youth? We ran a summer passport this year when we used a lot of digital apps and the rest, and actually we were surprised by the very mixed reception that digital apps that we had all assumed would be welcomed with open arms by those younger than me, and it wasn't always the case. Thank you.
Would you like me to respond to that?
Yes, please.
Thank you. So in terms of the school ambassadors, they're currently only in the north of the county. We focused on, that was a focused piece of work to try and support the applications for the additional mental health support teams, which we weren't successful in securing. It is a pilot programme that was run by Hampshire CAMS, and I think the plan is to roll it out wider across Hampshire, but I would have to find out a bit more about that and get back to you. And in terms of the Think Ninja app, we've during COVID suspended contract monitoring with most of our providers to allow them to, carry on and focus on delivering services throughout COVID. And one of the things that's missing for us at the moment, which I'm happy to go away and find out and report back on, is the uptake of the Think Ninja app. It hasn't been as, certainly when it was first rolled out, which was well before COVID, the uptake wasn't that brilliant. It's aimed at all young people under 18, but I think there are elements of it which perhaps aren't that appealing to some of the older young people, which is why we need to look much more closely in partnership with our young people at a range of different apps which might be able to meet their needs. I think, you know, we have this blanket offer and it isn't for all young people, so it's definitely a piece of work that we need to do.
Thank you.
Very helpful. Thank you.
Anyone else?
I have Alex Whitfield and then Christine Holloway.
Thanks, Jackie. Alex?
Thank you. So yes, I would endorse the comments about a really helpful update on a huge range of work that's going on. I wanted to just pick up on the CAMS bit, and I hadn't seen the figure before of the hospital admissions for self-harm in Hampshire and how they compare to the UK average, and that really is quite a shocking number. And I just wanted to say that from acute hospital perspective, that rings true, and it's growing rapidly. So you know, barely a day goes by when I don't hear of some challenges that we've got on our inpatient children's wards with young people who are distressed, self-harming, you know, having other problems. And I just wonder whether we know whether the hospital admission bit is because we have a greater level of self-harm, or whether the self-harm is kind of similar to the rest of the UK. It's just that there are other interventions that would then not require a hospital admission that might be in place in other parts in the UK. So it's kind of, where is the issue? Is it that we've got more young people self-harming and it's about their general mental well-being, or is it that we haven't got the right community-based response when someone does self-harm, and so we end up with hospital admissions? Does anyone know? Oh, Anna's put her hand up. I'm thinking she might know.
Yes, Anna, would you like to reply to that?
Yeah, I'm happy to respond to that. So I think, Alex, part of that, I think a big part of that is a missing puzzle piece in the community response. And one of the bits of work that's currently in our restoration and recovery piece across mental health in Hampshire is bolstering our community-based crisis services. So particularly in Hampshire, there is a hospital assessment and home treatment team, which, because of the number of hospital assessments that need to be done due to young people being admitted for self-harm, the intensive home treatment element of that really drops off, and actually that is the bit that needs bolstering so that we can provide young people who are in community treatment with a much more sort of robust wraparound package of care to hopefully then prevent those hospital admissions from continuing to rise. So that is currently, there is a funding plan in for that, and we're hoping that that's going to be agreed.
Thank you. Christine.
Sorry, Chair, would you mind if I just came in on that point as well?
Yeah, if you want to come in.
And what I'm about to say, it would probably not be very welcome, but I feel I'm duty bound really to say it. But the other bit of this, I would argue, Alex, is the Children's Commissioner published a report in, I think it was February this year, which highlighted the disparate levels of funding for CAM services around the country, and 4 of the 5 Hampshire CCGs were in the bottom 20. So I think that's, and I'm afraid that's probably part of the story here as well.
And could I just say that the acute hospitals would welcome more funding going into CAMS, and even if it meant less funding into the acute hospitals, because the right place to look after these young people is at home, not in our hospitals.
Yeah. Well, I hope your colleagues agree with you, Alex, and the other acutes, and you're not making yourself a hostage to fortune. Okay, Christine.
Hello. I'm not going to talk about the whole report because it's an amazing amount of work and an amazingly thorough report. I just wanted to pick up on item 7 in the slideshow, the one called Co-Design, Collaboration and Procurement to Enable System Integration. I'm hoping that when it says co-design there, it means co-design with service users, not just co-design with other providers. Because I mean, I'm sure it does. Sorry, I was just checking really. Because as we've agreed, we need to make sure that we cover co-design in all our reports to this board. I was a bit disappointed that where it says under the baseline, very honestly, there's engagement during the procurement stage, but limited at the co-design stage. I was disappointed that therefore under aims or activities planned or challenges, there wasn't any mention at all about how that baseline was going to be improved and how there's going to be more co-design in the future. So I just wondered if you could speak to that.
Who would like to take that?
I can pick that up.
Super, thank you.
So Christine, yes, you're absolutely right. Co-design is implicit in what's there. I think my view on that is that the individual agencies, to kind of different degrees, because working with different sets of service users, are quite good at co-production in isolation. What we're trying to do in this first 12-month action plan is make sure that we're really clear about where the best places are to work together. And then we will absolutely look at how do we bring in the different ways in which we do co-production currently, individually, how do we bring that together and deliver those shared priorities. So I think that, I absolutely see your point about, why isn't there a name there? But what we've tried to do with this action plan is make it a 12-month action plan. It's about what we're going to do now until next March, and then I would hope that you'd see in a future action plan something that talks much more explicitly to the point you've raised.
What your reply sounds absolutely fine, except that what you're going to do in the next 12 months doesn't appear in this plan either. Could you add it?
So that's in the action plan. So we're developing the joint commissioning board. We're developing the strategy that sits underneath that. We're focusing on the Section 117 and the mental health work together, and we're doing a huge amount of work across children's services and public health. So I think they're in there, but they're in bullet point form. I'm really happy to give you more detail on those if you'd like that, Christine.
No, I think I'm misunderstanding, because I said, why is there nothing in there on co-production? You said, don't worry, because this year everybody's doing it separately and then we're going to bring it together. But surely there ought to be something in there saying our plan is to bring it together, building on what everybody's been doing this year, or something that recognises that that it's being done this year, even though perhaps not in the perfect way.
Mm-hmm. Okay, I mean, I'm happy to look at the wording.
Thank you. That's great.
Thank you, Christine. Steve, you've just put up the Children's Commissioner's report.
Yes.
Yes. Can that be circulated to members?
It's a public document, so yeah.
Samaya, perhaps
I'll do that, Councillor Fairhurst.
Super, thank you. And Simon, did you want to come in at some stage?
No, I'll put my hand out. Steve answered. There was questions around CAMS, and we can look at the figures in a different way.
Okay, thank you. Right, I see no other hands. Sorry.
I have Rob Cole and then Julie Amis, Chairman.
Okay, Rob, and welcome, Rob.
Hello. Sorry, most of my questions or points have been raised by other members of the board, actually. Particularly, I was answered by Steve and by Nick. I just wanted to point out that as a fire service, we do offer 4 different schemes around children obesity, self-harm, fitness and activity, all based around self-esteem. And we've lost an awful lot of the how can I put it, the referrals into those schemes. So we used to use the school nurses and other people, and we were getting some fairly good hits with that. And over the last year, we have definitely seen a decline there. And obviously in the report, it doesn't mention those areas. So I just wondered, as most of my other points have already been raised and answered, thank you, if I could just offer that out there for someone to have a look at for me, to see whether there's an option. There's definitely a pool for young people to attend the fire station and do these activities, so maybe something we could work on together.
Yeah, absolutely right, Rob. And I think what you've described is exactly what I was also describing to Councillor Grajewski earlier, that fewer eyes on children and the focus on the intensive stuff, but we're now building back in all of those early warning signs so that we can begin to get referrals flowing again into yourselves. I know those programs.
Perfect, thank you.
Thank you, Rob. Julie.
Thank you, Chairman. Christine's partly covered the point that I was going to make, but I was going to offer 2 observations.
about what I read in this report and what I heard during the presentations. One was around the consistent message around involving children and families, and that goes back to that point about co-design and collaboration, and that fundamentally needs to be how we operate in the context of our work. And the second one was the involving partners, including Nick's point about districts. And that's a consistent question that comes back to me in the voluntary sector when we're looking at, you know, whether it's how we recover, how we
Yeah, I think those are really helpful comments, Julie, and I don't disagree at all. I think the only other thing I'd just take you back to also some of the verbal bits I said right at the beginning, which is just to remember that we're in the bow wave now. We're in the midst of what so if you can argue that the NHS had its crisis in March and April with the numbers coming through the system, and we're in that now, so we're really running to stand still. So just be patient with us, I suppose, is what I'm saying there.
Thank you, Steve. Right, can I now take Jackie? You want to say something?
Just had one last question from Matt Nisbet.
Matt.
Thank you.
Oh, it was actually just to come back on some of the Think Ninja stuff, which we were talking about 5 or 10 minutes ago. I've looked at the Think Ninja app, and I think it looks really good, actually. I would agree with the comments that somebody made earlier that it's probably more appropriate for younger teenagers than older teenagers, but it does look like a really good product. The thing I wanted to mention really was that it doesn't seem to have been well publicised or advertised, so I think a lot of my GP colleagues will be unaware of it, to be honest, which may be part of the poor take-up. But I've told as many people as I can. I mean, I don't know, Alex, if people in the emergency department will know about it, for example, but it is out there. It's just a question of telling people, I think.
Okay, so perhaps we need to have a bit of publicity campaign in the schools and youth clubs and everywhere else that young people congregate. Yeah. Okay, thank you. Can we just go to the recommendation, which is actually, I think people need to be congratulated on the amount of work they've done so far, and we look forward to you coming back later. But shall we just note the report? Does anyone want to disagree with the report? Sorry, Jackie, I'll leave it to you.
Thank you. Can I just ask if anybody would wish to abstain? No. Does anyone disagree with the recommendation to note the report? No, I therefore take it as unanimous in favour then, so that recommendation is carried. Thank you.
Thank you, Jackie. Can I just say we haven't finished yet, but what I'm going to suggest now is a 5 or 10 minute break for everyone. So you can get a cup of tea or coffee and get a little bit of exercise. Public Health are always telling us we must stand up after so long sitting. So if I could ask you to come back between 1:45 and 1:50, and we'll get started on our our penultimate item, that would be good. Okay, thank you. Right. Barbara, I think you're going to introduce this one for Julie.
Thank you, Councillor Fairhurst. So I want to welcome Julie and Energise Me and her report. The interesting thing I think that she's going to show is the impact of COVID-19 on physical activity. And we've heard right at the beginning from Simon around the impact of COVID and the inequalities that have come from it, the excess risk from COVID for certain parts of our population. In considering this, we're really looking at how can we actually affect risk and what is modifiable about the risk to the general population from COVID. And we're using this presentation to illustrate that regarding exercise and obesity. And I guess really what I want to point out to you all is how within our health and wellbeing strategy, particularly across the board through all ages, exercise and obesity are very big factors that are involved in the way that we look at population and our own health. And it's an area that people can help themselves with. So I think we ought to listen to Julie's presentation with a view to actually what change can be affected, what can we actually say we will do to deliver the health and wellbeing strategy and how that will affect our population's health and wellbeing.
Thank you, Barbara. Julie, over to you.
Thank you, Chairman. I'm just going to briefly start with the report and just to say that there were 3 parts to that report. The first one was giving the kind of context to highlight the existing inequalities that we had to tackle around physical activity before COVID hit us and some of the progress that we'd made towards those targets that we set ourselves. We were, in fact, increasing activity levels across Hampshire and Isle of Wight, and I mention Isle of Wight because our data comes across Hampshire and Isle of Wight, and we'd also managed to narrow the gap between men's and male and female activity levels. So we were making some really good progress. As you will see in the report, there's other stories behind that because in some localities it's not quite the same story, but the trajectory was really positive. But then the second part of the report moves on to the impact of COVID and on people's physical activity levels. And very early on, Sport England commissioned Savanta Comres to carry out research across a period of a number of weeks to look at what was happening. At the same time, they also did some research around what they called local voices. And that was Sport England reaching out to a number of their contacts and connections and networks and so on to look at what was happening right down at local level in some of those disadvantaged communities. And both of those pieces of research have then influenced the work that we have done through the COVID period and continue to do now. And some of that you can see in the appendices, and particularly around the Tackling Inequalities Fund. And what you'll see in the awards that have been made is that there are a number of organisations that are not your traditional sports clubs or leisure centres, although there are some examples of that, but very much organisations like Home Start and organisations like Breathe Easy that are supporting people with long-term health conditions. So what we've been able to do as an organisation and as a sector is be able to make connections to organisations and people that have trust with some of the groups that we were trying to target, and to be able to provide funding to help them build activity into their own work. The final part of the report kind of looks ahead to some of the work that we need to do, that we need to continue to do. One was around a social prescribing application, which I'm pleased to say this week we were notified that we were successful in that application. So we're going to take part in a social prescribing piece of work across our region to look at how we can match supply and demand and innovate around different people that might be experiencing disadvantage and might benefit from physical activity. So we're really looking forward to starting that piece of work and getting that recruitment underway very quickly. And I know that my colleague Helen Fisher is listening to this conversation. I really got to record my thanks to her, because she pulled together an application across a region very, very quickly with the support of all our regional partners. So that's the kind of report, and if that's all right, I'd really just like to take that report as read and move on to the presentation that you've got in your pack. And it starts with a Marmot quote around, once lockdown went into place, it exposed the fault lines in our society, those who could work from home, those who could not, those who could retreat to holiday homes, those that were in crowded flats, those with income reserves, those who could not afford to buy food, etc. What I've got to tell you is that all the research points to, with physical activity, that the same things apply. The physical activity levels amongst those that are disadvantaged for different reasons are lower than those who are not. So if you bear that in mind when I move through this presentation. So the next slide moves on to something that's headed small area estimates. And this is the map from the November 2018-19 active lives data for adult participation in physical activity. And you will see in a visual format where our highest levels of inactivity are. And I suspect that many of you that are on this call right now will relate to some of those areas, and you will be able to overlay other factors, other health factors in those areas. And that's why physical activity can, if we can tackle get people moving, it is going to help with some of those challenges. And then if you move across onto the next slide, that's how the map translates in numbers to people in different groups who are inactive. And again, I stress that this was pre-COVID-19, and we will not get an idea of whether COVID has increased those numbers until probably March 2021, when we'll get another data drop. So people in those age brackets around 35 to 74 years, 204,000 inactive, 82,000 people over 75 years were inactive, and you can see other numbers within there. I just will point out because I have been asked twice about this in the last week, NSEC 6 to 8, that refers to low socioeconomic groups. It's the ONS way of categorising what occupations people are in. So that would be your lowest, the NSEC 6 to 8 would be the lowest socioeconomic group. You might know it better in that terminology. Then the next slide is a timeline of a COVID-19 timeline. And colleagues put this together because I think it's a really good visual way of showing, one, when the pandemic struck us and we were going into lockdown, but then how quickly different parts of our sector responded. And what I do want to stress is that I am talking on behalf of the sector. That's, our district councils, our national organisation, Sport England, it's all our voluntary sector colleagues, our schools, etc. We've mapped those points where people stepped in, organisations stepped in to try and minimise the impact of COVID on people's physical activity levels. The messaging was really strong throughout and featured in the daily briefings about, how people could go out for that daily physical activity. So the message is strong, and I think that what we've picked up through the research is that people understand the need to be physically active. Sometimes, though, that's not very easy, and the case studies that I pulled together just an illustration of this. So using that data, we then started to try and get some stories from people that were responding to the challenges that they were facing. So meet Sophie, who started running during COVID. Sophie lives in a flat and didn't have very much space where she could be active. And so she picked up the Couch to 5K app and started running through lockdown. All of these have a longer case study. I've just picked them out because that lack of outdoor space for some people was stopping them being active. Sophie's response was to pick up the Couch to 5K free app, downloadable from the NHS website. And I can tell you that 858,000 people downloaded that between March and June. That's national figures, I hasten to add. And that was up 92% on the previous year. So Couch to 5K, and I'm one of them. I've blogged it as well throughout my Couch to 5K experience, have got active during the COVID period with that app. The next one I wanted to highlight was Ros. Ros is a physiotherapist at Royal Hampshire County Hospital, but she also runs a small business, Love to Move. And Ros works in outpatients, but has moved to work on the wards during the crisis, and wrote a blog for us about her experience taking her activities online to be able to continue to support those with long-term health conditions. And the point one of the points that I wanted to make there is that we all have people in our workforces that can help to make a difference around people's physical activity levels if we can find them. And oh, I've just touched something that I shouldn't have done. Hopefully I'll get back to normal there. Moving on to the next one, Amanda from Momentum, based in the Winchester area, actually, have successful dance classes, including one for wheelchair users. During COVID, what Amanda did was take those classes online. Really incredible story, this, because what wheelchair users themselves were reporting was that they found themselves able to do even more in the classes because they didn't have to have the effort of getting, themselves into a car to get to the class and, use effort in that way. They could channel more of that into the class online. But the other thing is, I think someone mentioned this morning, was those classes have gone across the country, but also abroad and gone international. So that's been one of those, really nice surprises of COVID and this period, and finding out, and they will continue to make an online offer going forward. And then the final one was moving a referral class online. So this was Christine, who specialises in GP exercise referral for older people and those with chronic conditions such as COPD, diabetes and arthritis, etc. And again, what Christine has been able to do is to continue to engage those people to keep them active during COVID by taking those things online. So we have seen a digital revolution in some cases around physical activity. That's not to say that, we are extremely aware that there are people who would be excluded because they don't have access to digital. And so it's not going to be a solution for everyone in every situation. But I think it does add to the offer that we can make to our communities, as well as helping the sector come back and start running classes back in our community venues and so on. So I think what we wanted to spend most of the rest of the time that we've got available to us doing is having a discussion, and that's the final slide, about what action we, our organisations and our networks can do to help communities be active. And I know Nick mentioned this earlier, but one of the things that I would just finish on is those kind of inadvertent things that we do from, behind our desks in our offices and just from our own experience of life, I guess, and not making assumptions, and why it's really important for us to work with the communities themselves. We've been doing some work in some what we call place-based work in an area of Hampshire. And we started from a position of mapping everything that was happening in that area. And we ended up calling it the map of misery, because it told us everything initially from the data that we had that was wrong with that area. But then we spent a lot of time literally walking the streets, speaking to people that live there, speaking to community leaders. And what we found was that the community themselves really like living there. They don't very move away from their area very often, and quite the contrary to what that kind of map of misery, the data was telling us. They're really happy to be living in that community and so on. And the other thing that what we noticed was when we were walking around, lots of green space, but then signs that say no ball games. So what are we telling our community with that particular sign? What we're telling them, that we don't really want them to be active, or not, we don't want them to be active on that particular piece of grass. I don't know, but it's those sorts of I think what we've reflected on is that it's very easy to pour yourself into data and make an assumption about an area. But actually, when you get under the skin of an area and you talk to the people that live there, that work there, etc., it tells a very different story. I'll stop there, Chairman.
Thank you, Julie. Can I just come in and say, I think this just shows really how important it is that we actually do keep in touch between the districts and the Hampshire County Council, and that we do join up our work, as was pointed out to us earlier. And in fact, what is happening around work in the communities in primary care networks, as Julie has pointed out, is that we have social prescriber linked workers who actually do get out to the people that need help. That they use the what matters to me approach, and some of the what matters to me is to be put in touch with the ability to get out, to exercise, to get fitter, and to therefore keep well. And so I think we can absolutely say that the districts and the local primary care networks and those local communities are connecting, and this will be the beginning, I hope, of a revolution about actually population health management, helping people to care for themselves and to get fitter. And of course, we do know that exercise and mental well-being go very strongly together.
Thank you, Barbara. Matt, did you want to come in?
Yeah, I mean, I agree with Barbara about the districts. I think it's a fantastic presentation, Julie. Thank you. I mean, I think for the public health people on the call, like Simon and Rory, it's a bit of a holy grail kind of question, really, how you get people to exercise more and why some people do and some people don't. If you could bottle the benefits of exercise, I think you'd be quite rich. One of the things I really enjoyed about the lockdown period was seeing so many people cycling more. And I think there is a real opportunity for the county council in all of this. I know that there's a consultation open currently about transport, but certainly transport infrastructure that makes it easier for people to cycle, I think would really benefit people's health and well-being, as well as our communities. So as well as primary care networks being important, I think it's important to recognise that this is not something we can do alone. It does really require a system approach.
Thank you, Matt. Christine.
Thank you. That was the perfect moment to carry on from Matt. I was going to make a point that I have made many times before, but I'm absolutely not going to apologise for making it yet again. And that is that this is a really, really good description about how to encourage people to take exercise more. And it's got some really good things in it. But it's only half the picture. And if we really want people to take more physical exercise, then we have to look at how physical exercise can be built into people's daily lives and what the county council and other people involved with transport can do to make physical activity be part of what people do as they do the rest of their lives. People on their way to work, people collecting the children from school, people going and doing their caring responsibilities. People shouldn't have to make a separate decision. Oh, I must take some exercise, because of course that's what goes when you're stressed out with trying to cope with life, COVID and everything else. There's one reference in the whole report in paragraph 19, which says some people are walking and cycling more, using their commute time differently and valuing the difference clean air and safe spaces bring. And yet that is the only mention. And I would like, if you look at paragraph 33, sorry, I'm just finding it so that I can look at it as I'm talking to you. Paragraph 33 talks about, it needs to have a link. It needs to talk about the fact that the county council is already embarking on reviewing its local transport plan, colloquially by the councillors referred to as LTP4, the fourth iteration of the local transport plan. The local transport plan focuses on active travel. The local transport plan is already agreed by your transport people that it has to have an awful lot more on getting people walking and cycling, even going by the bus, because at least you have to walk to the bus stop. Can I please make a plea for this Health and Wellbeing Board to consider that transport is actually a health issue and is a physical activity issue, and to bring travel within the scope of the physical activity strategy and actually look at things in the round, so that we're encouraging people to build exercise into the other activities of their lives, not make it a special thing that you have to choose to do. And I've just seen the I asked 3 or 4 years ago for us to invite the transport people to a meeting, and I was said yes, but nothing ever happened. So could we please put it on the agenda for the next meeting, so that this board can influence what's in the local transport plan at an early stage?
Christine, we're going to discuss the agenda for the next board meeting after we've finished this item. So if you could just leave that just there. Simon, before I come to you and then back to Julie, I could just say that Councillor Perry made a very good point in the chat room that when we talk about the local districts and boroughs, we should also remember the parishes, because they're very close to the people in their areas. Councillor Perry, did you want to add to that, or are you quite happy? Okay, Simon.
Thank you. Really great to hear the work Julie's done, and we're really pleased to be working in partnership with Energize Me on this. I think it just a few things that kind of strike me that we are moving forward in the right direction. We, as Matt said, we all recognise the huge health benefits of physical activity, and that's why we need a kind of coherent plan that involves everybody, our district colleagues, and it does require some of the structural changes we talked about, so that the parks don't have please don't play on here and those kind of things. We need to think about the way our health services works. Actually, we don't think about musculoskeletal problems as a kind of medical problem, but actually where does physical inactivity play in that, so that we get people active first of all, and kind of really move to an early part of the pathway. I think just to build on Christine's point, we are absolutely engaged in the transport plan. As public health people, we are embedded in that process, working very closely with the Director of Economy, Transport and Environment. So, we are putting our public health view in, and it'd be great to hear an update there at a future board. But please be assured we are working really closely because it's about active travel, and we see those together. So working with Julie and that with her team on that plan.
Thank you, Simon. Graham, you wanted to come in.
Yeah, thank you, Councillor Fairhurst. I really endorse the approach, and the importance of physical activity is absolutely critical and crucial. The point I wanted to make, and it's really picking up on Councillor Perry's comment, what we've seen in terms of support, but also restoration and recovery for people across our communities is a huge amount of, I think, absolutely superb work from Local communities, parish, district, borough councils, the voluntary community sector have absolutely been in the vanguard, along with colleagues across Hampshire County Council, NHS, primary care, and so on, which is helping people to get moving again following lockdown. And Steve made reference earlier to the impacts on younger children in terms of the anxiety of returning to school. We're absolutely seeing those same characteristics in those people that for a whole range of reasons have been shielded for an extended period of time. And there's a huge amount of work taking place, which I think in a true spirit of co-production is absolutely superb in terms of the way that it's being supported by all organisations, voluntary, charitable, community, parish, district and county, along with NHS colleagues, as I say. That there is something for me, which is how do we blend messages about physical activity with overall messages about how you can support your well-being and mental health? Because for some people, and it may be a minority, but an important minority, I would suggest, the very words physical activity may be a turn-off. Whereas indeed we all know the benefits of taking a regular walk, having regular exercise. It's about overall improvements to your mental health and well-being. So it's really how do we tread that path between the descriptor or the nomenclature that we use in order to deliver those improvements and outcomes for individuals, for families, for communities, and so on and so forth. So as I say, I really endorse the physical activity strategy. It's how we make sure that we make it truly inclusive and describe it in a way that sort of touches all of the buttons for all of our population, and link into some of those wider activity-based approaches which are not being described as physical activity. It's about well-being and getting going again. Thank you.
Thank you, Graham. Julie, do you want to come back at everyone?
Yeah, that's brilliant. I mean, you know, Graham, you're absolutely right. And I think that probably is a good lead into paragraph 33, which is about this, our next physical activity strategy. And I think it will be a question that comes up about physical activity. Do we talk about moving more, movement rather than physical activity? I mean, for sure, what we're talking about and why we use the terminology physical activity and not sport or anything else is, but all those access kind of areas like walking to physical activity are really crucially important, and we spend a lot of time with partners working on that. I think, Christine, I'd have no argument with you at all about active travel, and certainly the active travel team are colleagues that we speak to relatively frequently, and you'll know that I've raised in this board about the role that the active travel team can play in the physical activity strategy. What you allude to there is something that, and why I always say I'm not here talking on behalf of Energise Me, the organisation. I'm here talking about physical activity and the sector, because we can't do this. We're a team of about 15 people. We covering the whole of Hampshire and Isle of Wight. We can't do this on our own. We can't influence the whole system on our own. And this is why the question was posed to this board about all our many networks and organisations and so on that can help to make changes that will bring about a difference for our communities. The final thing that I would say is that the last paragraph around the physical activity strategy, we are taking a very different approach to how we pull this particular strategy together. And again, we'll be asking board members to help us with our approach. So there will be, that traditional consultation with, partners that we talk to all of the time. But what we're really trying to do, trying to achieve in this next strategy is having contact with the very audiences that we're trying to reach. So we've commissioned an external agency to help us with some consultation work So we can talk to people with long-term health conditions. We can talk to people, you know, to women, to people that live in communities that those or in those lower socioeconomic groups or in those disadvantaged communities. We have, over the last 3 or 4 years of our strategy, have built many more connections to organisations that have relationships with these communities, but also direct relationships. If you look at our website and some of the stories that we've pulled out of people who were previously inactive, doing virtually nothing at all, to people that have found a way to be active. You know, we've got those connections that we've built up over the last few years. But yeah, we'll definitely be asking colleagues on this call and involved in this board to help us reach those audiences, because the better that we do that, the more voices that we hear from that have that lived experience, the better our strategy is going to be, and the better our response, our delivery of that strategy is going to be.
Thank you, Julie. Can we go to the recommendations? I think it's on page 37 of your pack.
Sorry to interrupt, Chairman. I had Councillor Perry did have his hand up to come back on his point.
Ah, sorry, Councillor Perry.
I did, yes. Thank you, Liz. Sorry, I couldn't unmute myself earlier. I totally agree with everything that's been said, and certainly what Graham said there. I just wonder, in terms of the parishes and the voluntary sector, whether at some time this Health and Wellbeing Board could give some thought to organising an award scheme so that the parish that has done most to promote exercise and activity in its community gets noted and thanked. I think in any event, just noting that they've done it and saying well done and thank you is a good idea, but sometimes a bit of stimulation helps. So leave that as a suggestion. I'm not saying we want action now, but think about it.
We can certainly think about it. Of course, those areas without parishes might feel a bit excluded, but I'm sure we could work our way around that.
Sure you could.
Thank you. Right.
I have Councillor Grajewski with her hand up.
I was going to say, I can see one other
Yes.
hand. Whose it was. Right, Judith.
Yes, thank you, Liz. Just following on from what Councillor Perry said, and I think he makes his point well, some parishes are responsible for their local recreation grounds. We're lucky enough in Chandlersford to have a sports hall as well, which is run by the parish council. But I'm looking around, of course, the little names on everybody's boxes doesn't say where everybody's from. And while I know a lot of you, I'm just wondering, do we have a representative from HALC on this Health and Wellbeing Board? That's the Hampshire Association of Local Councils, Liz.
No, we have someone from the district and the boroughs. We have both officer and councillor representation from the boroughs and districts, but no one from the parishes.
Okay, thank you.
Yeah. Again, perhaps we need to think about that. Okay. Anyone else? And if not, we'll go to the recommendations on page 37. Jackie, shall I hand over to you? We'll take the recommendations 2 to 7 as a whole, if that's all right.
Yeah, thank you. Can I just check, does anybody wish to abstain? No. Does anybody wish to vote against? Oh, Christine, do you wish to say something or abstain?
I wish to abstain. It's not because I think there's anything whatsoever with the report as it stands, except that it only covers half the picture, and I don't want to vote for something which misses out what seems to me to be so essential, which is the infrastructure, the transport arrangements, the roads, and the world we live in.
Okay, thank you. I can confirm 1 abstention. Does anybody wish to vote against the recommendations? Oh, I saw Sir Roy Honey's hand up.
Christine's point has actually swayed me. I think it's really important we reflect those structural components. So I think I'll abstain with Christine on this.
Thank you.
And if I could just say that I think also as well, I'd like to abstain for exactly the self-same reasons.
Sorry, can I just interject to say that either Patricia Hughes or Rory Honey can have the vote? I don't think both of you get to vote because one of you is deputy for the other person. Am I right?
No.
Oh,
No, so Nick
Sorry.
Custian and myself.
Oh, Nick Custian, apologies, sorry.
Are both representative of the chief executives across Hampshire.
Thank you.
So,
Just because we have a number of substitutes and main members, I just wanted to ensure that only the people that are needed at this meeting are voting. Thank you.
So both Rory and myself are voting in our own rights.
Yeah, and I'll abstain too.
That is, sorry.
Matt, sorry, Dr. Matt Nisbet.
Thank you.
Thank you. So I have 4 abstentions. And can I just check, does anybody wish to vote against the recommendations? If you could verbalise, that would be lovely. Thank you. No. So therefore take it as a majority of members in favour of the recommendations.
Right.
Thank you.
Thank you, Jackie, and thank you, Julie, for all the work you and your organisation are doing. And it'd be good to see it taken forward in the future. Thank you. Right, if we go to agenda item 9 now, we're almost there, members. If you look on page 79 and 80, you will find the forward plan for future meetings. What I'd quite like to go is see if anybody's got anything they want on the agenda, and I know Christine has, but if anyone else has got anything on the agenda which is not there at the moment, but they would like to be brought forward to the board. Anyone? Christine?
Sorry, I was assuming that you'd already got transport on the list.
Oh,
yes,
no, I was leaving it till this item.
I'm sorry. Yes, please. Could we please have an item at the next meeting, because otherwise the ball will have got rolling without us. Looking at transport arrangements, their implications on physical well-being, and how we could influence LTP4, which is the local transport plan.
I mean, can I suggest something a bit broader maybe? I mean, I think it's really interesting the way that the conversation around physical activity has been so animated and passionate. I mean, it's obviously something which is of huge interest to people, and I think that's understandable. I mean, I think if we really think about what the single thing we could do to improve the health of our population would be, it's something that would actually have a massive impact, and maybe it's something that we need to dedicate quite a bit of time to coming up with some real practical actions. You know, maybe something kind of workshop style, or we can consider transport, but other things as well. It feels like it's been quite an important topic this morning.
Yes. Can I bring Patricia in first, Christine, because she had her hand up? Patricia Hughes. But I think she might have gone. Patricia? No.
My apologies. I did raise my hand and I put it back down again.
Ah, okay. Christine.
I was only going to say that I think that I totally agree with Matt's sentiments that we need to look at physical activity as a bigger issue. I'm just afraid within the what's the word I'm looking for, the dynamics of the Health and Wellbeing Board, that if we have an item on physical activity and it doesn't mention transport in particular, we won't have any transport colleagues there. They'll get overlooked yet again, and we'll miss our opportunity to influence the local transport plan entirely. And so could I suggest that it could be, even if we do if we do lots of general discussion on physical activity, can I please request that we specifically say one of the items we wish to look at is local transport plan 4, and we wish colleagues from strategic transport to be present?
Right, Christine, we can certainly suggest it. I'm not sure about the time frame, but we can do our best to make sure that that's brought back. Okay, thank you. Anyone else?
I've got Simon Bryan. I don't know if he wants to answer any questions. Or...
I was just going to pick up the points and just reflecting on that paper, which is really, really excellent paper by Julie. And yes, we can always go further. I think with the transport plan, I absolutely agree. And as as Matt said, a public health man, it's kind of my physical activity is my kind of dream pill. But I think what we need to remember, this is one forum where we discuss these issues. And actually, as a board, we have really supported physical activity and how important it is. There's many other forums and places we're going to discuss physical activity, including in the transport plan and the development of that, and myself's involved in that, and many other people. So I think there's something about just kind of recognising where do we need to work together and where do we want others to work together. And certainly as a board, I can take those thoughts through to the people writing the plan and make sure we work together. But I think there's something about being really clear what's our role. And I think, you know, we've highlighted inequalities this morning and highlighted physical activity and seen what the children's plan's doing. And I think as Barbara, as the kind of chair of Living Well, where physical activity, although not exclusively for adults, fits, we need to kind of work with Barbara to say, actually, how do we build this in through your leadership, and then Steve through his leadership, and then Graham through his leadership of those sections, to make sure physical activity is embedded and we influence the other parts of the system, which we can do, rather than just relying on it coming here, because I'm not sure that's the solution to having to improving the engagement. We need to kind of engage the others following the meeting today, which I can do on some of those aspects.
I suspect you might be right, Simon, but it might be worth getting a written update from board members so they can see that things are actually happening if we don't go down the other. Barbara, you wanted to come in.
Yeah, so thank you. Very much along the lines of what Simon has just said, Liz. I think what we have to think about is, what is this board about? So it is about the health and well-being of our whole population. And of course, all of these things will make a huge difference. We have a strategy, and our strategy ranges across the age groups, but actually things like exercise and obesity and all of those sorts of things can span the whole of the strategy. And I think what we can do here as a health and wellbeing board is to understand how different parts of the board, how different organisations that make up the board take responsibility for delivering on that strategy that we're all signed up to. So I don't think we can do all the work here in the board, but I do think we need to know about the work being done and make sure that we keep up to date with actually how different organisations are taking that responsibility. How Julie, for instance, is sponsoring exercise with others across Hampshire and the Isle of Wight, across all of the different levels, right down from parishes and local places up to what we need to do at scale, as Christine says, in influencing the active transport plan. We need to know about it. We can't do it. There is absolutely no time to hear about it all, but we do need to understand that members need to take responsibility, go back to their organisations and make sure they're delivering on what they can do, and make sure that we know that they have delivered.
Thank you, Barbara. Patricia Hughes, is that
Alex Whitfield first?
Oh, Alex, sorry, Jackie. Alex?
Okay.
I'm happy to let Patricia go if she wants, but so it was just on the forward agenda planning. First, a more general comment of that lots of the items are actually past agendas rather than forward, and I just wonder whether there's a different way of presenting this, perhaps as more of a, you know, so it's clear what's actually in the future, because I got a bit confused with the paper, but that was just a suggestion. And then the modernising our hospitals and health services programme, we've got down as a written update. If there is any room on the agenda next time for this group to really help shape how we make sure that that programme has got the health and wellbeing of our population at its heart, I would really appreciate that, because we've been doing a lot of engagement and consultation and involvement. But this is a huge investment in capital that's coming to Hampshire, but it's also a major change in how we're trying to provide care close to people's homes, you know, digitally or in local GP surgeries or in community settings. And I just think there's an opportunity for this board to really influence how that programme rolls forward. And I would hate to kind of it all be a bit of a fait accompli by the time we have a discussion at Health and Wellbeing Board. So if there is any room on the agenda, that would be my plea for the forward agenda setting.
Alex, can I just come back to you on that point? So we had actually reached out to a number of HHFD colleagues about this, and we hadn't heard back. I think there was some kind of an email issue where those emails are being sent back to us and we can't reach, for example, yourself or Amy or anyone else. All those emails bounce back. So I have flagged it to Amy, but I can talk to you about that outside of the meeting. But we did try to connect with you about this prior to the meeting.
That's very strange. So Marie from HOSC is in communication with us all the time, and those emails work. So let's try and find out what's going on there.
Absolutely.
So, yeah.
Yep, I forwarded the transcript so you can see at your end what it is, and it's happened once before.
Oh, okay. Thank you. We'll look into that. Thank you.
Thank you for that, Alex. Patricia again. Patricia Hughes.
Yes, just looking at the forward programme, and I completely agree with Alex. I got a bit confused as to which items were coming forward and which ones are in the past. But I think there's probably some real value building on some of those commentary around the broader delivery and what we're trying to do across our whole population in terms of getting the districts to come back and report next time round. You'll know that there is a large piece of work that's happening through the recovery scheme. And the recovery on the community side has been under subsidiary, I can't even say it. It's been passed down to districts to deal with. So I think there needs to be a report on where we're going in terms of that community recovery, because the community recovery includes a lot of aspects associated with mental health and well-being in its broadest context. So I'd like to put that on the agenda for next time around, because I think it's going to be really important with where we are in the whole of that bow wave, as was described before, in terms of requirements.
You're muted, Councillor Fairhouse.
Sorry, thank you, Councillor Huxted. Anybody got any more burning issues they think need to come before us, or that they would like to see come before the board? No? Okay, well, we'll take away the comments and we'll see what happens. Okay, so thank you all very much for your patience and your ability to sit here for this long. And I look forward to seeing you all at the next meeting. Thank you.
Thank you.